it's a very important subject what we have addressed today. And when we talk about NHA, it's like it's a National Health Authority's apex body responsible for the implementation of flagship public health insurance scheme, which is called Ayushman Pradhan Mantri Jan Arogya Yojana. And when we say Pradhan Mantri, it's like health for all. PMJY, when we talk about PMJY or when we talk about ABDM, there are the two strengths of NHA. We say that we need to create a system where health is accessible to all in a time-bound manner, and the best services are available to the country people. While talk about Nirantar Shiksha, we have been organizing these Nirantar Shiksha that people should be aware what exactly issue. And when we say Nirantar Shiksha, we talk about prevention. Prevention is more important to us because we find that prevention is, we always say and we always heard here that prevention is better than cure. And this prevention, which is important to us, is basically saying about that now it is a time when we understand our own issues. We understand our problems and we try to basically make sure that the problems are being taken care in a time bound manner as well. We at NHA have been organizing the Niranta Shiksha for a very long time. We are also having our virtual training sessions about which talks about their claims, which talks about scan and share, which talks about the HPQA packages, what the packages we have. Because all the multiple things are being talked about and in a regular intervals. Coming to this basically cervical cancer, we find that it's very difficult to talk about. It's still a very challenging issue in our country. And when we talk about cancers, this cervix is very third most important cancer with an incidence of 18.3. That is 1,23,907 cases, and the second leading cause of death with a mortality rate of 9.1% as per GlobeCon 2020. When we talk about the age standardized incidence rates per 1 lakh population was 18, while 5-year prevalence rate across all ages was 42.8% per lakh population. It is too high. As per the national, because we have a national cancer registry program, registry also, the cancer for breast, cervix, uterine are the most common cancers among females. Cervical cancer accounted for 6 to 29% of all cancers amongst the women in India. And Pampure district in the state of Arunachal Pradesh, India has the highest incidence rate of cervical cancer, that is 27.7 in Asia. We all know that health is a state subject, but health is primarily a state responsibility as per the Constitution of India. The Ministry of Health and Family Welfare, Government of India, and the central government body that looks after the health sector in the country. Apart from that, there are private institutions, NGOs, philanthropic organizations who are actively involved in the various healthcare activities, providing preventive, promote, and curative services to the people. And we are trying to facilitate that in a much more and an effective manner at NHA as well. But if we see, there is no comprehensive national screening program in India at present. And the lifetime screening prevalence of 29 among women and 30 to 49 has been reported from the National Representative Survey. It says that it is very important. Now, MOHFW has recommended the visual inspection of national inspection of acetic acid screening method for age to 30 to 65 years with a 5-year interval since 2016 as per the operational failure. So important is that we need to understand what are the issues which we are finding it now. What are the remedies and what are the preventive? We have very good speakers with us today. One is Kausar Kidwai ji, who is basically looking after she's the head CSR in Medanta. And very actively, I mean, I have been seeing her very actively participated in much of the programs and for especially for the cervical cancer. Some of the incidents what I have heard from him while working with the MP government and all and being in ministry because we all have worked together. So when we talk about Kausar's experience is very different. And it was very great that she accepted our invitation, saying that now it's a time that I need to share my own experience, which is much important for the general population as well. So if I talk about the Kausar, she has a 16 years experience in the driving advocacy, strategy, implementation, partnership building, social campaign, and social stakeholder management in the critical consistently delivering the mission critical results. And I'm very thankful to her because she has been working with MP SACS. She has been working with so many different organizations. Like she was senior manager for country program in clinical health access initiatives. Then she has been state senior consultant, United Nations Population Fund in Fab India, and many others. I mean, if I will start talking about her, there will be so many things to talk about, which will take another time. बट अपने आप में अगर एक बात कहूँ तो अपने आप में एक शख्स हैं जिन्होंने बहुत सारी चीज़ों पे काम किया है और ये एक्सपीरियंस है उनका लेडीज के साथ जुड़ा हुआ है. शी हरसेल्फ है वर्क फॉर दिस. मुझे उस बात की बहुत खुशी होती है जो लोग खुद अपने आप काम करते हैं. एंड कौसर एक ऐसी शख्सियत है जिन्होंने अपने आप को जोड़े रखा उन महिलाओं से जिनको ये परेशानियां थी, और परेशानियों के साथ साथ उनको निदान भी दी गया कि भाई आज क्या टाइम है कि जब हम निदान कर सकें इन परेशानियों का. सो और इन परेशानियों का निदान उन्होंने कई तरीकों से किया. उन्होंने वेब इतनी ज़्यादा अवेयरनेस करवाई, आईसी रीजनल लैंग्वेजेस में बनाना, उन तक पहुंचना, उनके घर घरों तक पहुंचना, उनकी जानकारी बढ़ाना, हेल्थ कैंप्स करवाना. अगर मैं एक बात कहूँ तो कम है, बट बहुत सारी चीज़ों में उन्होंने हम बहुत ज़्यादा काम किया इस विषय पे. और आज जब मेदांता में बैठी हैं तो उसमें भी बैठ के उन्होंने यही एक बिहार के लिए एक नया इनिशिएटिव उठाया है कि वो बिहार के लिए इस विषय पे, क्योंकि बिहार, उड़ीसा, इस तरह के जो स्टेट्स हैं जिनमें काफी समस्याएं हैं, उन स्टेट्स को लेके शी इज वर्किंग अगेन और एक नई नीति जैसी बनाई है मेरे सारे एक्टिविटी के जरिए कि वो जो है इस नीति के जरिए वो लोगों तक पहुंच सके. तो मैं कौसर, इट्स अ प्लेजर दैट वी ऑनर यू. और ये हमारा भी अच्छा वो है कि आप हमारे साथ जुड़ी आज, और एनएचए जैसी जगहों पे, मतलब जहाँ से हम मैक्सिमम लोगों तक पहुँच सकते हैं. अगर आज आप देखेंगे हमारे वेबिनार में आपको सब तरह के लोग मिलेंगे. हमारे डॉक्टर्स भी हैं, एसएचए के लोग भी हैं, हमारे एनजीओज भी हैं, इंस्टीट्यूशंस भी हैं. एवरीबडी इज देयर एंड वी हैव अ गुड स्ट्रेंथ अक्रॉस द कंट्री. अक्रॉस द कंट्री, व्हेन आई से कंट्री तो मतलब पूरे से लोग हमारे साथ जुड़े हैं आपको सुनने के लिए. तो अब मैं फिर से आपका बहुत अच्छे से अभिनंदन करती हूँ और आपको कहती हूँ कि दोबारा से ये बात कहती हूँ कि इट्स अ प्लेजर दैट यू हैव जॉइंड अस एंड नाउ द डाइस इज योर्स. आपको मैं आप संभालिए कमान और जरा बताइए लोगों की आपके अपने एक्सपीरियंसेस कैसे रहे और किस तरह से हम प्रिवेंटिव मेजर्स पे काम कर सकते हैं. थैंक यू सो मच एंड ओवर टू यू कौसर जी.
Good morning, everyone. Um, I'm really very grateful to NHA, Ms. Vinita Srivastav, for considering that all the initiatives that have happened in the past need to be spoken of. And this is a wonderful platform where these initiatives will reach out to each and every individual across the country. So, really very honored to be associated with NHA. I'll just introduce myself. Vinita ji, you've done a commendable job in introducing me, and that's a very kind introduction and a gracious one. However, in the last 16 plus years that I have spent in public and private sector, and also with my, when I was selected at, and you can see that background, I have been able to create some ripples in the ocean. I will not say that it has been a very outstanding kind of work, but I will still say that these are small steps, created some ripples in the ocean. And today it is all a result of the work that has gone by in these last few years that you and I are meeting virtually. So to just begin with, rather than deep diving into the discussion, I would just want to say that 8 years back, when the program on cervical cancer was initiated, I was leading that program. And when I would talk to people, a lot of people would confuse cervical cancer with the cancer of the spine. So I will just point it out if you can see in the camera. So this is the cervix. They thought this was the cervical spine and this was the cervix, and that's the cancer that I'm talking about. So at one given point in time, people did not even take cognizance of a part of a woman's body that was called cervix. That was one. Um, During those days, naming anybody, but I received a call from one of the very well-known institutions, wherein they said that if I could connect to a radiotherapy service provider, there was a woman who was very critical, battling with stage 4. And I kept thinking to myself that I couldn't even identify one such location. The woman collapsed in the next 4 days because of multiple organ failure. From that time till the time I met another learned person who said that I asked him this question, that is it okay if I deep dive into this space, because I'm not a doctor, but I really understand, being a public health professional, that it's important for everybody to join hands to be able to deal with something which was as grave as cervical cancer. So he said, Kausar, tell me one thing. Does anybody get hassled when they are told that you have diabetes or you have blood pressure? And do you think that, you know, uh, you will never be cured? I said, no, that's never the case. He said, what do you say when somebody gets diabetes or hypertension? I told him, sir, it's all about management of the disease. I said, that's exactly where we stand with regard to cancer. The disease needs to be picked up early. The disease needs to be managed. And if there are methods of prevention, we must go ahead and prevent it. And 8 years down the line, I received so many calls from people who want the vaccine. I come to know, and I have been a part of such initiatives. I come to know of health camps that are conducted at medical colleges, where first year, second year students come forward, self-fund the vaccine and take these vaccines. So great job by all of our gynecologists who have been leading this back from the front, to a point that today we are conducting this webinar, and this is one of the many efforts that NHA has put together. So again, thank you very much, everyone, for coming in these numbers. And I would just like to talk about the disease in a nutshell. And this is cervical cancer from a layman's perspective. I'm really hopeful that this will enrich you in a manner that you will have a lot of thinking points. I'm just sharing my screen. Are you able to see my screen, please?
Yes, ma'am.
Yeah, thank you. Improving health education and awareness about cervical cancer. As I said, that people were not even aware about the part of the body called cervix. So cervix is basically the mouth of the uterus. Vinita ji has already spoken about numbers, and if we were to look at the latest figures, we have increased cervical cancer cases in the country as per GloboCan, which is the Global Observatory for Research on Cancer, by another 5,000. So the total number of cancer cases, new cancer cases that are detected, are about 1.27 lakhs in the country. Now, this is also, let's first try and understand what is the correlation between HPV and cervical cancer. You've heard about the HPV vaccine, you've heard about the cervical cancer disease. So HPV is the virus which causes cervical cancer. This virus would be of nearly 200 plus types, but all of these viruses will not cause cervical cancer. If you can see in this graph, basically the peak prevalence of any transient infection will happen, transient infection of any high-risk HPV or carcinogenic HPV will happen in women who are in their teens, or if I may say, it is with the onset of sexual activity. So, which is why you will see peak prevalence of HPV infections in women wherein the onset of has happened. The peak prevalence of any kind of precancerous condition will happen after 10 years. So it's very important for us to understand that while we are talking about HPV infection and any abnormality which is associated with cervical cancer, that will take at least 10 to 15 years. It will not show up immediately. So here, what I'm just trying to establish is there is a very big window of 10 to 15 years where a person, when gets infected with HPV, which is high risk HPV, will show some kind of abnormality. And it is only in her mid 35 to say 50 years that you will see any prevalence of invasive cancer. So the peak prevalence of invasive cancer will only be seen in say 40s, mid 40s and early 50s. So that is what is very, very different about this particular cancer. And if I were to talk in terms of stages of cancer, this cancer in layman's term has a stage 0. And that is the term that I think resonated with the community a lot. I have been in hospitals in the community talking to them about cervical cancer, but it actually scares them. So the word we generally use is abnormality. The word we generally use to explain to them is something which is 0. The word we generally tell them is there is some abnormality on your cervix with very minimal treatment, which is just about 30-second or 40-second. And I would here really like to spell out the efforts and the initiatives by Government of India, wherein the guidelines were revised in 2019, where thermal ablation devices are now approved as per the Government of India guidelines to treat cervical cancer using thermal ablation devices. The treatment time has gone down from 11 minutes to just about 40 seconds. So when the abnormality or aplasia or neoplasia, as you say in medical terms, can be treated in as low as just about 30 to 40 seconds, I think this became a win-win situation for everyone. Now, it's very interesting to see that we have a Government of India program that started in 2016 on non-communicable diseases, especially addressing the framework for common cancers. And the 3 cancers that were listed out were cervical, breast, and oral cancer. And if I were to together talk in terms of the overall number of cases, then this is more than 40% that oral, breast, and cervical cancer cases constitute to. Here it is worthwhile that we understand that as per NFHS 5, if you were to look, just about 1 to 2% people in the country have ever undergone a screening. So the problem here lied with people do not undergo for screenings, regular health checkup, which is why cancer shows up at later stages. And that is what was the problem statement here. Any cancer showing up at stage 3 or stage 4 or in the later stages will always have a very difficult pathway in terms of treatment. It will have a very difficult pathway in terms of the financial burden that it brings on the family. And it is physical well-being and financial well-being that are all impacted in one go. So one thing which I would want to underline here is early detection and prevention can go a long way when we are talking about a disease like cervical cancer. So if we were just to look in terms of what is the challenge of cancer in the country, we have nearly 14 lakh new cancer cases that are diagnosed in the country annually. Now, this poses a very big burden on the economy of the country. There are 2 big challenges here. One, more than 50% end up in mortality. 50% से ज्यादा लोगों की मौत हो जाती है because ये सारे cases जो होते हैं ये stage 3 या stage 4 detection वाले हैं. As you go ahead, as we keep discussing this, it'll be worthwhile to look at the numbers of cervical cancer. Now, as I said, that there are about 1.27 lakh cancer cases, new cancer cases diagnosed for cervical cancer. The 5-year burden or the 5-year survival rate of these cancers is nearly 3.4 lakhs in the country. Now, 3.4 lakh people, it actually takes away nearly 4,000 crores from our economy, because treatment for these women is very, very challenging. And as I mentioned, 57% or more is out of pocket expenditure. So, because cancer care is not available closer to the community, the access is very, very weak in terms of provisioning of medication. I think it's very important that these wellness initiatives should be taken up, and these wellness initiatives, which will promote prevention and early detection, will go a long way in number one, preventing the disease and identifying the disease at an early stage, where the cost of treatment will go as low as 10,000 rupees. And this is all embedded in Ayushman Bharat. I mean, that is the foresightedness and the vision of NHA that I would talk, that this is already a part of Ayushman Bharat, where screening and treatment of neoplasia or dysplasia is already embedded, whether low grade or high grade. As I just spoke of, I mean, the cost of treatment at a high at 3 or 4 is higher. When you detect the cancer early, the treatment costs are very, very low. So I think the anthem should be that you have to drive prevention and early detection, and you have to start now. This is one of those cancers which is preventable. Now, actually talking in terms of a cancer and then saying that it is preventable may probably not go hand in hand. But yes, this cancer is preventable. And there are 2 strategies that can be taken up upfront. When we talk about primary prevention, vaccination of girls in the age group of 9 to 14 years is very, very important. It is very essential that we start providing education to girls and boys at an early age. It has to be customized, definitely. But when we are talking about kind of education to prevent a particular disease, we have to start educating a generation. And when we are talking about educating a generation, it will come from educating our girls and our boys. When we talk about secondary prevention, then we will be focusing on women as per Government of India guidelines in the age group of 30 years to 65 years, advocating for screening. Now, there are different modalities that are available for screening. Government of India advocates for a VIA, which has to be done once every 5 years. It is a very good test which can help with screen and treat at the same time. However, there are other better performing tests that can be taken up and should be taken up, because our health lies in our own hands. It's very important that we are aware and then we make the right choice, that we should go ahead with the right screening methodology and discuss with our doctor in case if any further treatment is required. We also like to address a immunocompromised cohort here. And in the previous experiences of mine, where I have worked with Clinton Health Access Initiatives, Karkinos Healthcare, it was all about not only talking about general population, but also thinking in terms of who are the immunocompromised or the vulnerable cohort. Which is why I would want to underline here the women living with HIV. These women who are living with HIV are more vulnerable to this particular cancer, because cervical infections are very common in these kind of women, and censoring does not happen. I'm very grateful to State AIDS Control Society for giving me this opportunity to run a program where we were able to screen nearly 4,000 plus women in the state of Madhya Pradesh. And I'm very happy to share that HPV testing was recommended, and with HPV testing done for these women, we were able to save nearly of the 40% plus positivity that we're seeing, we were able to safely treat all of these women who showed signs of dysplasia. And also at the same identify cancer at an early stage. With this woman who was HIV positive with no symptoms, and she showed up with signs of stage 3 cervical cancer. So this is a silent cancer. Symptoms will not come up. The only way to protect yourself is to be aware and then move ahead in the right direction. And treatment, we all know that there is surgery, radiotherapy, chemotherapy, and palliative care. When I talk in terms of global strategies, WHO advocated for cervical cancer elimination 2030, and 90% of the girls, and this is the 90 anthem, which has been ringing in everyone's ears to be able to deal with the public health problem. 90% of the girls should be fully vaccinated with HPV vaccine. 70% of these women who are screened with a high performance test should be done at the age of 35 and 45. And when I say a high performance test, it always helps in kind of increasing the screening interval. So a VIA will have to be done at the interval of 5 years vis-a-vis an HPV, which you can actually be safe even if you increase the interval of screening for 10 years. And of the women who are identified positive, 90% of these women should be treated with the new technologies that are available, which lead to very minimal complications, and it can actually save you from a grave disease like cervical cancer. Now, here is some of my challenges that I faced when I was on the ground. Now, I was in the district hospital, as I mentioned, all the facilities and talking to people, different cadres, whether they were Ashas, Anganwadi workers, ANMs. So during one of my interactions, I said that, let's start creating brand champions. And Madhya Pradesh was the first state of implementation where the entire strategy for cervical cancer screen and treat program was laid down. I'm really very grateful to the proactive leadership of state government of Madhya Pradesh. Capacity building was done. Master trainers were trained from very minimal awareness to a time where nearly 3,000 plus people in the state could screen for cervical cancer and have all district hospitals operational for treatment of dysplasia and all tertiary hospitals operational. The concerns were very different. And the concerns were that when we started educating the Ashas, we promoted them for screening. So it did take us quite some time to even tell them that this is a very simple and a normal screening technique. And once you get yourself screened, you will be the brand ambassadors. So we were able to convert about 63% of Ashas whom we counseled into successful screenings. And actually that led to the mass screening of 2.5 lakh women as a part of the first screening initiative in the country. Now, talking in terms of what kind of languages we adopted to, what kind of examples we heard of, a lot of times women said, who came to the hospital because we were advocating for opportunistic screening, they said, मुझे तो कोई परेशानी नहीं है, मुझे अपनी जांच क्यों करानी है. So वहां से हमने हमारी लैंग्वेज कि आपको तभी जांच करानी है जब आपको कोई परेशानी नहीं है. आपको जांच तब नहीं करानी है जब आपको कोई परेशानी आ जाए, क्योंकि तब तो बीमारी आपको दस्तक दे गई है. जब आपको कोई तकलीफ नहीं है तब आप अपनी जांच कराएं. जांच कराते टाइम जब हमने उनको ये समझाया, हमने कैंसर वर्ड का इस्तेमाल कभी भी नहीं किया. हमने सिर्फ इतना कहा कि थोड़ा सा इन्फेक्शन हो गया है और इस इन्फेक्शन को रोकने के लिए सिकाई करनी पड़ेगी. प्लेसेस वेयर क्रायोथेरेपी वाज बीइंग डन, तो हमने कहा ठंडी सिकाई होगी. प्लेसेस वेयर थर्मल एब्लेशन वाज बीइंग डन, वी सेड गर्म सिकाई. So I realized that this was getting very well accepted in the community. And as a result of this, their concerns for screening, became much less. With Ashas being our brand champion, that also kind of really helped because they themselves had undergone this particular procedure. Treatment also led to the resolving of multiple such queries. And now these people became our brand champions in the community. A very big cohort came from the State Rural Livelihood Mission because they were the more aware and the educated cohort. They were counseled, they were encouraged, they came forward and got themselves screened. And all of these efforts in sync with the other development partners, NGOs, state government, field level workers, SRLM members, led to the treatment of nearly 63% women who were identified with any kind of abnormality successfully. Uh, the solution lies in our hands. We have to actually go ahead and drive the programs. It's very important that our facilities in the public sector, because I'm a firm believer, the only way to impact community at scale is through our public sector. And NHA has given us a wonderful way forward where at the cusp of public and private healthcare lies your well-being. And whether it's public sector or private sector, you have access to both of these institutions. Please get yourself screened. Please think that it's better to screen yourself when you have no symptoms. Wellness is the driving factor. We should none of our programs should be illness driven. They should all be wellness focused. I think I have come to the close of this discussion, where I would want to just suggest a couple of things here. One, a mother-daughter initiative can do wonders, when we are talking about cervical cancer elimination in line with WHO. Vaccinate the daughter, screen the mother, educate the daughter with the vaccination program, and you will see that you are educating a generation. And it is only with this initiative and many other such initiatives where we are constantly talking about awareness and eradication that we will actually see this happen. And I'm very, very hopeful in our ecosystem that when we were able to eradicate polio, this is another cancer which has been threatening women and looking at us directly in the eye, that we will be able to combat with this and just come out from the clutches of the disease. Thank you very much.
Acha. And it was very nice. I mean, you learn. I mean, preventive measures are very important. वो जो लोगों को समझाने का तरीका कि गर्म सिखाई ठंडी सिखाई लोगों तक पहुंचने का तरीका, that is the most important thing. That's why we thought कि किस तरह आपने वहां पे मतलब एक एक महिलाओं से मिलके काम करना बहुत मुश्किल कार्य है. It's not that easy. कहने पे बड़ा सुंदर लगता है कि हाँ ये हुआ, बट जब करने जाओ तो it's very difficult. And that's the best thing. ये बहुत बड़ी समझ है लोगों की कि आपको पहले समस्या से पहले समाधान किस तरह किया जाए. वो एक बहुत इंपॉर्टेंट चैलेंज था. एंड यू हैव डन योर बेस्ट. आई मीन बहुत आपने कहा ओशन अ ड्रॉप इन ओशन, बट वो ड्रॉप जो होती है वो बहुत इंपॉर्टेंट होती है. वो समझने की बात है कि किस तरह से कि उस ड्रॉप ने क्या अख्तियार किया किस के जीवन में. आप समझ रहे हैं यू आर सेविंग लाइव्स. इज नॉट ओनली वन लाइफ बट द इंटायर फैमिली इज बीइंग कनेक्टेड विद दैट. So that's very important. You are not saving one life, but you are saving the entire family. You are saving the entire and the family that's constitute the community. So that's very important. And I'm thankful to you for giving your time and इतने मुझे पता है बहुत ज्यादा बिजी रहते हैं सभी लोग, लेकिन ये है कि इतना अच्छा समय देना और एक कार्य के लिए समय देना है बहुत. So I'm really thankful to you and a big thanks to you for this on behalf of NHA as well, from my side and NHA both. So now we have another speaker who is Dr. Professor Aruna Nigam. She is the head of the department from the Hamdard Institute of Medical Sciences and Research, Delhi. She has been president-elect Indian Society of Colposcopy and Cervical Pathology. 200 पब्लिकेशंस इन्होंने किए हैं, नेशनल और इंटरनेशनल. एडिटर हैं पैन एशियन जर्नल ऑफ ऑब्स्टेट्रिक एंड गायनेकोलॉजी की, और करीब 8 किताब की एडिटर रही हैं जो बेसिकली ड्रग्स ऑब्स्टेट्रिक और गायनिक के recent advances of obstetric and gynecology and postmortem hemorrhages. बहुत सारे अवार्ड्स उनको मिले हैं, काफी जानकारी और बहुत सारा काम किया मैंने कई चीजों में। कई अरुणा को बुलाने से पहले क्या, एक्चुअली हमारी एक रेकी होती है तो हम उसमें ये भी देखते हैं कि हमारे जो डॉक्टर्स आ रहे हैं उनकी जानकारी, और वो कितनी वृहद जानकारी है। तो व्हेन आई रेड अबाउट अरुणा, एक्चुअली इट वाज सो मच ऑफ थिंग्स व्हिच हैज बीन डन ऑन हर पार्ट। एक बहुत अच्छी बात है, एक अच्छी शख्सियत जब हमारे बीच में आती है तो हमें सीखने को भी बहुत मिलता है, और हमारे जो लोग हमारे सारे हैं समझो, बिकॉज Aruna, let me tell you, we have people across the country, and you will find from the district to the states. So everybody is there. वो हर तरह के लोग हैं जो जानना चाहते हैं कि हमारी लेटेस्ट टेक्नोलॉजीज क्या है, हमारी ट्रीटमेंट क्या है, किस तरह की नई थेरेपीज आ चुकी हैं मार्केट में, एंड बहुत सारी ऐसी चीजें हैं जिनको हमें अब अख्तियार करना और सीखना भी है। एनएचए पूरी तरह से सहयोग करता है इन सब कामों में। So that is the concern, and I would like to invite Aruna for her talk now. So Aruna, she's there. So over to you. This is yours now. Please. Thank you.
थैंक यू विनीता जी, बहुत बहुत शुक्रिया इसके मुझे निमंत्रण देने के लिए। एंड दिस टॉपिक इज वेरी नियर टू माय हार्ट, एंड आई हैव बीन इन्वॉल्वड इन द प्रिवेंशन एंड ट्रीटमेंट बोथ ऑफ सर्वाइकल एज अ गायनेकोलॉजिस्ट आल्सो, एंड कौसर किदवई को भी मैं बहुत क्लोजली जानती हूँ क्योंकि उनके साथ भी हमने कार्य किया है। जो मध्य प्रदेश में चाइल्ड सोसाइटी थी जिसके अंतर्गत इन्होंने काम किया था, तो वी ऑल्सो वेंट टू एजुकेट एंड मेकिंग दोज लेक्चर्स एंड एवरीथिंग। I would look forward in doing the work for cervical cancer with you, with NHA, Kausar, Kidwai, NGOs. Really, this is the target as a president-elect of Indian Society of Colposcopy and Cervical Pathology, which is closely involved with all cervical carcinoma. So without doing any delay, I have just revised a few things of my lecture. I will not go very high. I will like to be at the mid level so that the information regarding the prevention and treatment both are covered, although the topic given to me is a treatment, but I will somehow scientifically touch the preventive methods also, because that is a very important component of the cervical cancer treatment. So let me share my slides with you. Okay, share, right.
आराम से स्लाइड शेयर हो जाए, अदरवाइज नंदा को भेज के आप करवा। अच्छा,
ना ना कोई,
ठीक है, दैट्स फाइन। नाउ
that
you can see.
let me make it slideshow from current slide. Okay. So let's start with how I have made my lecture. See, webinar, it is very difficult to make it interactive, but still I would like to make it interactive, and I would request if I can get questions in between, that will be wonderful, so that जो एक तारतम्य होता है लगातार एक ब्लैंक स्क्रीन के सामने बोलने का और उसमें अपनी कंटिन्यूटी बिल्कुल वो हो जाती है, तो बहुत अच्छा रहेगा अगर आप बीच बीच में कोई जो भी प्रश्न आए वो मुझसे पूछ लें। So how I'm going to talk about is that I'm going to talk about the risk factors, the early detection and prevention of cervical carcinoma, or mantra given by a WHO, that is a 1979, the clinical features of cervical cancer, so that you can identify the disease. What are the changes? Now we need to know the latest also about it. So what are the changes in HP histopathological examination, which is very important. WHO has given 1 year back. The treatment strategies as per the staging, understanding something about the surgery, not a complete thing as a postgraduate, but yes, what is radical hysterectomy and the principles of radiotherapy, because there is a lot of advancement from the primary prevention till the prevention. So we have heard from Vinita ji and the Kausar ji that we have a very high load of cervical cancer. See, the 2 minutes which I spent just now, one woman died of cervical cancer. This much is the load of the disease. So we all have to come together to fight with the disease, and we have to catch the disease before it attacks us. That is the motto, and that is the motto which has been given in May 2018 by a WHO for a cervical cancer elimination by 2030. So अब हम थोड़ा सा याद रखेंगे and बीच बीच में भी I will go on saying so that everybody remembers what is 90, 70, 90 and what we have to do till 2030. So it is a most common genital malignancy in India, second most common malignancy in females in India, and every 7 minutes, one woman die of carcinoma cervix in India. Such is the load of this disease, and we have to fight the disease. Most common type is squamous cell carcinoma. Although the peak incidence is 55 to 60 years, but the incidence increases after the age of 35 years, definitely. You see, all over the world, if you see in the West, the incidence is around at 48 years. But we have an earlier age that is at 38 years. So we have to work fast on this disease. Coming to the risk factor, which are very important for any disease to prevent at all levels. Okay, so these are the risk factors which are very important. Early marriage, we have this thing. Sexual activity at younger age, multiple sexual partners, and this is not have female having a multiple sexual partners. If the male partners have a multiple sexual partners, then also this female is going to have a high risk of cervical cancer because of a very important factor, which is human papilloma virus. Now, poor genital hygiene, smoking, multiple pregnancies, weakened immune systems, and the OCPs, all these are actually going to decrease the immunity of the patient, HIV infection, and also it opens the cervical canal. As we told, in general, people think of cervix is this, cervical is this, but it is not that. It is the mouth of the cervix. Most of us you are healthcare workers, doctors, nurses, NGOs, so you know that it is the cervix. And why the cervix is so much prone for this disease? Why it is so? We need to know this, only then we can understand. You see, भगवान ने ना फीमेल को बड़ा यूनिक बनाया है, उसके ऑर्गन्स को भी बड़ा यूनिक बनाया है. बच्चा बढ़ता है, यूट्रस बढ़ता है, इतना बड़ा हो जाता है, बट डिलीवरी होती है वापस इतना छोटा हो जाता है. कैसे? Every month female menstruate, वॉल बढ़ती है, छोटी हो जाती है. सो वी हैव लॉट ऑफ पोटेंशियल ऑफ रीजनरेशन इन दिस एरिया, lot of multiplication of the cells in this area, and that particular area of cervix where there is a lot of multiplication of cells known as a transformation zone in the cervix area. And a beautiful photograph which I have put, you just see this area. You can see this area. This area is prone for infection because there are a lot of actively dividing cells. So activity hogi, वहां पे infection आएगा. So this area goes on regeneration throughout the menstrual cycle in a different manner, and this area is affected by a various infection, early age of marriages, number of pregnancies, multiple sexual partners, HIV infection, lowered immunity, all those things, because this virus, which is responsible for the 90% of the cervical cancer, attacks this area, which is naked, which is right. So this virus attacks the cells of this cervix, and where there is an active division, it goes on the base of it and remains there. Once it remains there and persistently remains there, and because of the lowered immunity or frequent infections, we are not able to take out this HPV infection, then it causes a cervical cancer. So you see, once the HPV infection, this is very important to understand, because now you have to make understand the patient why we need to act from all the way to catch the disease, treat the disease, prevent the disease, and eliminate the disease. So HPV infection, this virus is causing infection at the early age, right? Because once sexual activities starts, this patient or this woman is prone for HPV infection, which is responsible for more than 90% of the cervical cancer. But don't think that every patient who is having a HPV infection is going to develop the disease. No, this is the advantage of this. disease in the prevention, that once the infection occurs, it remains there. If there is a persistent infection, it causes cellular changes. Okay, so you can see these cellular changes, right? Now these cellular changes also remain there for 5-10 years to develop into the carcinoma. So from the infection till the development of the carcinoma, you have a good 10 to 15 years or more to catch the disease, to treat the disease. And that is the concept which you need to understand. And most common infection in India is by 16 and 18. Out of this, 16 is very common, and these are called as high risk HPV infections. And whatever our diagnosis is depending, because everything is now HPV based, whatever preventive method is there, that is via the HPV, right? So this is the natural history of disease, that the infection remains there. It clears in 90% of the females. But because of bad sexual habits, multiple sexual partners, lowered immunity, persistent infection, this can lead to 3 stages before the development of the frank cervical carcinoma. And here we can do the early diagnosis, that is a secondary prevention method, right? So it is very important to understand, I hope all of you understood, that there is a HPV infection. If it remains persist, it leads to the precancerous stages, which remain for 5 to 10 years, and then there occurs a development of disease, and we need to catch up the disease during this period, right? So whenever we talk of a elimination of the disease, there are a level of prevention, that is a primary prevention, secondary prevention, and tertiary prevention. In a primary prevention, we try that the disease should not occur. So the infection should not occur. If it has occurred, we try to catch up early. And if the disease has occurred, we try to treat the disease at the maximum potential. Okay. So there are methods of very good vaccines available with us, which just now talked, slightly giving a detail, because I think this is a very important part of my lecture, that there are methods of primary prevention, and that is the motto of 90-70-90. That is 90% of our females between 9 to 14 years should be vaccinated with this vaccine. And we have a Cervarix, we have a Cervavac vaccine, and we have a Gardasil vaccine, which acts against these viruses and don't let them harbor inside the cervix. Vaccinate your young girl, then this disease can be prevented, and that is the motto. At many places, the government is providing this vaccine free of cost. And this year and last year in the budget also, Nirmala Sitharamanji has also talked of that they will include this in the budget, a certain number of doses for our young girl to be provided free. So this vaccine by Serum Institute, our own company of India, has invented this vaccine in India. We have trials. So this is the cost-effective vaccine which can be used. And in now WHO says that only one dose is sufficient in age less than 15 years. But in India, we are still using a 2-dose schedule for less than 15 years. And above that, we are using 3-dose schedule, especially for Cervavax. Boys can also be vaccinated from the this HPV vaccine. Now, suppose the infection has occurred. Now, we can detect infection by diagnosing the HPV virus or the cellular changes. And these are the components of the secondary prevention, that is the screening methods. So primary prevention is a HPV vaccination. Secondary prevention is by using a technology to detect, that is the pap smear via villi, right? So this HPV DNA screening can be done in all the female age aged, very best, although not very, still cost effective, not available freely. But then you can go for a pap smear or a via. Pap smear, it is just a scraping of the cells from the cervix. We take and we detect the cellular abnormalities. All the female more than 30 years of age, as per WHO or as per our society guidelines, all the females more than 25 years age should be subjected to screening by a smear every 5 years. At least 2 screenings at the age of between the age of 35 to 45 years have to be done to detect this CIN lesion or a pre-cervical lesion. Then we can apply 5% acetic acid. If this facility is not available, you can use just a 5% acetic acid, put over the cervix and see the white lesion, and then the disease can be detected and you can treat simultaneously. And for this, even the ASHA workers, nurses can be trained, and we are training all of them. So I talked of 90, that is 90% should be vaccinated. 70% of these women should be screened between the age of 35 and 40 years. Now, what is the last 90? Last 90 is, out of these 70%, the females who have been diagnosed with the disease should be treated. So I hope all of you remember 90, 70, 90, right? So that is a very important component. I would like to highlight that the 70% of the patient who are diagnosed with CIN lesions, that is the cervical intraepithelial lesion, which are a precancerous cervical lesion, right, can be treated very easily with a very small surgical or a conservative methods. You don't remove to the cervix. You just, as Kausar has said, Thandi Sikai, Garam Sikai, and these are the probes, small probes, or that can be done in the OPD by just a cryoablation. This is a cryo instrument which uses nitrous oxide and ablates the abnormal area of the cervix for treatment of the disease. This is a thermal ablation probe which is applied only for a 30 seconds and treat the disease immediately. Or if it is a higher grade lesion, we can just sweep off with the special instrument which doesn't come very costly and is available at most of the places, can be done in a local anesthesia or a local analgesia, just the abnormal area with the help of a cautery and remove that part, and that is known as leap. So this is the method by which these females, if diagnosed with CIN lesion, can be treated. Now coming to, if you have developed a cervical cancer carcinoma, what are the treatment strategies, how we can diagnose it early, to the coming to the main part of it. I hope till now it is clear. So this is one part of my lecture which is finished. If any questions are there, I would like to take up so that, okay. Somebody asked, please explain about the cervix. So let me explain in 1 minute time. This is cervix. This is uterus. And this is the mouth of the cervix. If I show you the photograph of the cervix, you can see this is whole uterus. This is uterus. This is vagina. And the cervix, it is the mouth of the uterus. So this is cervix. And once you do a speculum examination, it looks something like this. And you have to focus on this area, which is prone for infection, as I told you. So this is regarding the cervix, right? So I think I dealt with this question. Please explain about the cervix. So now I move forward and I go with this. Oh, why it's not okay, right? Okay. So now you should be knowing what are the clinical features of the CA cervix. So generally, patient can be asymptomatic if it is a CIN lesion, or patient presents with postcoital bleeding, if it is a very late stage, cachexia, abnormal bleeding, vaginal discharge, pain. In a stage 3-4, urinary symptoms. Stage 3-4, again pedal edema, but most of the time it should alarm you that the patient is presenting with vaginal discharge, abnormal bleeding, or postcoital bleeding. Any patient coming to you like this should be taken general physical examination, systemic examination, and most important part is the speculum examination. If you are a healthcare worker, please don't leave the opportunity to examine the patient's cervix. Please do the speculum examination. You can put at that point of time 5% acetic acid, and if that area becomes white, that means it is suspicious and need to be referred to a higher center. Right? So we do a speculum examination, we do a vaginal examination, we do a rectovaginal examination to detect the extent of the disease. Coming to the, what are the histological types of this disease? You see, this is the old confusing classification which has been changed in year 2021. And now there are only 4 entities which have been given: squamous cell, glandular cell, mixed cell, and a germ cell. This squamous cell is the most common type of cervical carcinoma. Any other type, if appears on biopsy, then it becomes a bad prognostic feature. Okay? So this is very important to know which type of carcinoma we are dealing. And whenever we get a suspicious lesion, immediately on a OPD basis, biopsy can be taken with a very simple instrument and sent for a histopathological examination. Now, these 4 types have been divided into various types. But as you can see, what I want to highlight is the classification is now dependent on whether it is HPV associated or HPV independent. A very important point, because that is the point which prognosticate the disease. Right? This carcinoma can spread by a direct or lymphatics or hematogenous, that is by blood. I had just made this line diagram. If a few of you want to understand how the cervical, because the most common spread of cervical carcinoma is by a lymphatic drainage. And once I had to talk on the treatment strategies, we need to know the lymphatic drainage of the cervix, right? So you can see this, I have made a cervix, right? And these are the vessels. This is aorta, right? This is common iliac artery. This is external iliac artery, and this is internal iliac artery. Now from here, the lymph node supply goes to these arteries, and gradually upward movement of the lymphatic drainage occurs. So whenever we are talking or arteries of the cervix, in the initial stages, we can just remove this part of the lymph nodes easily and do the treatment. And that is called as pelvic lymphadenectomy. Pelvic lymphadenectomy. Pelvis, right? So with hysterectomy, we combine this procedure. That is why you need to know how much extent of the lymph node has to be involved in the different stages of cervix. And as I go forward, how much are the chances of different stage of the cervix? Stage 1, 2, 3, 4. I think, okay. Stage 1, 2, 3, 4. That spread of the disease is there. So this staging is very important. And initial stage, as you can see, the studies shows that in the initial stage, there is very less lymph node spread of the disease. So in these stages, we can go for a conservative treatment, and there is no need to remove the whole of the uterus. You can just cut the part of the cervix in a young females it we encounter, and the disease can be treated. But if it is a later stage, as you can see here, 5%, 15%, 25%, 30%, the disease is spread to the upper part of the lymph node increases. And now we need to combine with the extensive type of lymphadenectomy to treat this disease. Okay, so let's see what is the staging of the cervical carcinoma for your point of view, for everybody who is attending this. So one thing I told you, that there is a CIN lesions. That is a precancerous lesion which can be treated very easily with the conservative method like cryo, LEAP and the thermal ablation. But once it has become a carcinoma, we have to stage the disease. And I tell you, this is the first carcinoma which have been staged in all the medical diseases. In all the medical diseases, this is the carcinoma which has been staged. Okay. So now there are a lot of changes gradually occur, and latest change was there in 2021. And what are the changes which have been occurred? You see, if it is a stage 1, that is the disease is confined to the cervix. Disease is confined to the cervix. But then this disease can be again divided into 1A and 1B. This 1A can be divided again into two parts, 1A and 1A2. By the depth of invasion, if it is less than 3 mm or more than 3 mm. If it is less than 3 mm, again I told you the conservative measure just by removing the part of the cervix is available. But beyond this, we have to give for a major surgical procedures. If it is a stage 1B, it has been again divided into three parts by the size of the tumor mainly, which is less than 2 centimeter, more than between 2 to 4 centimeter and more than 4 centimeter. If it is a stage 1, B1, B2, we can treat the patient by a surgical method. And you see, government is providing under Ayushman all these surgeries. So anybody can go to government hospital, and even these Ayushmans are there in the private hospitals also. So you can go and get yourself treated. Don't think that the government is not providing the treatment for the disease, or for CA cervix, the treatment is not available. It is available, and very good specialists at every level which can treat you. Okay? So this is very important to know that till stage 1B2, we can treat the disease completely by a surgery. Okay, stage 1B3, because the tumor size is large, we go for a combined radio chemotherapy. Right? Now coming to stage 2. Stage 2, that means it has gone beyond the cervix. Right? So stage 2, when beyond the cervix, it involves the vagina. So this was the cervix and this was the vagina. If the upper 2/3 part of the vagina is involved, that is the birth canal, then it comes into stage 2. Now this is stage 2 have been divided into 2A and 2B. This 2A can again be divided into A1 and A2 according to the size of the tumor, less than 4 centimeter and more than 4 centimeter. Less than 4 centimeter, we can go for again surgical treatment. So as you can, and beyond that, we have to go for a radiotherapy. No surgical treatment is recommended beyond stage 2A1. Understood? The concept is that till stage 2A1, you can go for a surgical treatment which is available easily. And we have an expert as well as the gynecologists are also trained in this surgeries, available at all the hospitals, in most of the hospitals. Right? But once it is stage 2A, 2 and 2B, you have to refer the patient for a radiotherapy. And remember that again, there is a very good advantage in the treatment of the advanced cervical carcinoma stages, and we have a very good radiotherapies available at many of the centers and many of the cities, and these focus the radiotherapy radio frequencies at the specific site so as to have a minimal side effects, right? So you can treat the stage from the stage 2B onwards with the radiotherapies. So stage 3, that means it has extended beyond the lower third of the vagina, or it has gone to the periotics, and stage 4, it has gone beyond the true pelvis. I'm not going into the detail of it. Now, whenever we talk of a management, okay, so then we have to consider few of the things regarding the, let me see if there are any questions. Okay, I will take this question on the vaccination and will be happy to take these questions on a vaccination. Okay, okay. So management depends upon the age, if the patient is pregnant or she wants to become pregnant, according to the stage of disease, size of the tumor, and many comorbidities like obesity, nutritional status, diabetes, hypertension, right? So these are the 3-4 things which we need to consider whenever we are planning the management of the cervical carcinoma. Besides staging, I told you surgery is to be done till stage 2A1, but type of surgery will depend upon the other factors also. So let me take it to you. Whenever any patient you see, you suspect, diagnose, because these are the things which can be done at the level of the MBBS, routine family practitioners, or you can just suspect. So few of the things you can do on your own, because many of the investigations government is providing free of cost to all of us. So besides going for a routine investigation, biopsy, see, if you know how to take a biopsy, you can take a biopsy. Don't, patient compliance is very bad. Our society is still developing towards the female reproductive health, and we have to work towards it. If the patient is, female is coming to your OPD, we should not be losing any opportunity to screen her for any disease, whether it is a diabetes, hypertension, or cervical carcinoma, breast carcinoma, because these are the things which we can do at that point of time only, right? So now, whether we need a higher end procedures for the pre-op workup of these patients, cystoscopy, proctoscopy, no, these are not needed unless until patient comes with the blood and urine or blood and stools. Suspected bladder or rectal involvement should be confirmed by a histology. Ultrasound, yes, should be done, but MRI PET scan is optional. We can just stage, this is the only disease which can be staged just by the clinical examination and taken up for the surgery, because the surgical advancement and the surgical treatment of this disease is very good. So if you diagnose the disease, state the disease that it is till stage 2A1, right? And do the workup, you can take up the patient for a surgery. High-ended investigations are not needed, but yes, if it is available, you must go for it. Okay? But don't think that you cannot do the surgery before MRI. This is a common, because you are investing 10,000 rupees, 20,000 rupees on a MRI PET scan. इसमें तो उसकी surgery पहले ही हो जाएगी. So we don't lose the opportunity to treat the disease, right? We need to treat the patient, because you see, one female being treated, one house is being saved, one home is being saved. There are so many people associated with this female, and we have to look after the female health in that manner only. Now I'm going to just focus on in next 5 minutes on a stage-wise treatment. So I already talked of that stage 1 to 2A surgical treatment. Beyond this is a radiotherapy. So this is a beautiful table if you want to understand that once we talk of a stage 1A1, less than 3 mm, simply removing the part of the cervix will do if we want to conserve the uterus. Otherwise, extrafacial hysterectomy will do. But if the invasion is more than 3, there is a lymph vascular space invasion, then we go for a modified radical trachelectomy or radical hysterectomy along with pelvic lymphadenectomy. Stage 1A2, that is between 3 to 5 mm. Yes, we need to go for a pelvic lymphadenectomy along with conservative or complete surgeries. Stage 1B1, we talked of, we need to go for a radical hysterectomy along with lymphadenectomy. Between 2 to 4 centimeter radical hysterectomy. More than 4 centimeter anytime, if it is 1B3 or 2A2, we should go for a chemoradiation and pelvic floor radiotherapy. Beyond that, there is a combination of the chemoradiotherapy which is to be used in the stage 2A-B onwards. Now, this is the specimen just to show you how the radical hysterectomy, how this radical hysterectomy is different. There is so much of advancement in the hysterectomy surgery that we need to know how we can decrease the morbidity associated with radical hysterectomy or hysterectomy. So we have so much of advancement that the type of surgery can be conservative in a sense that we can save the nerves. So gradual with the advancement, we have a nerve sparing hysterectomy, which is being done nowadays for this carcinoma cervix. Different classifications have been described over the time, and I don't want to the details. If there are postgraduates, we can go, you can go through by reference of Kurl-Morrow classification. But if there are no postgraduates, I'm going to skip these slides regarding the different classification of the hysterectomy. But yes, I would like to tell you the steps of what we do actually in a radical hysterectomy, that we give a long incision, we examine all the bladder and the lymph nodes, then we dissect all the spaces around the cervix and ligate the uterine artery at origin, remove maximum part of the ligaments and the associated areas attached to it so that the complete disease is being removed. And along with this radical hysterectomy, we go for a routinely internal and external lymphadenectomy. I told you the lymphatic drainage. So lymphatic drainage has been divided into the levels by the presence of the lymph nodes, right? So this is, I told you, cervix. So once we are this is aorta, common iliac, external iliac, and internal iliac. So if we are removing this part of lymph node, this is called as level 1 lymphadenectomy. If we are removing the higher stages is there, this is called as level 2 lymph node. That means we are removing till common iliac, and above it is a level 3 lymph nodes which are around the aorta. Right? So level 3 and level 4 is around and above aorta. So that is not generally done. In those stages, we go for chemotherapy. So there are various studies. One point I would like to highlight, there are many trials regarding the type and the route of hysterectomy available with us. Till date, all the trials have shown that we should not be going for a laparoscopic hysterectomy in cases of cervical carcinoma. As per the trials, all the trials, it has been observed there are a lot of increased recurrence with the laparoscopic hysterectomy, although the laparoscopic hysterectomy nowadays is advisable in all the cases, but regarding carcinoma, still it is suggested that we should be going for an open hysterectomy. This is the important point which I want to tell. Now, we need to prognosticate the patient with the disease. So that depends upon the stage, type, grading, size of bulk of the disease, lymph node metastasis, molecular markers, age, lymphovascular space invasion, and the functional status or any comorbidities. So all these factors are associated, and we need these are the prognostic. If there is a higher stage, then prognosis is of course bad and need to go for a, other therapies also. So this are there any complications associated with the surgeries and the radiotherapy? Yes. No surgeries without complications. So there can be acute complications that are blood loss, fistula formation, embolism, febrile morbidity. Subacute complication, that means bladder dysfunction can occur, that patient will have a problem with the passage of the urine. But now with the nerve sparing hysterectomies, the incidence of this has decreased. Why we prefer this surgery over radiotherapy in the initial stages? Because the complications are less with the surgery in the initial stages. Vagina is initially shortened, but later on it lengthened. But here the fibrosis occurs. So if the patient is actively, young patient, coital activities there, we don't prefer radiation in early stages. Ovaries can be conserved in a surgical therapy. Bladder atonia is lesser, and surgical mortality is almost equal in both the cases. You see, once you have treated, carcinoma can never be cured. This is the sentence which you have to tell whenever you are treating any patient of carcinoma or counseling. It cannot be cured. It needs to be followed. And that is why in carcinoma, we say talk of survival rate, that is 5-year survival rate, 6 years, 10-year survival rate, or the recurrence of the disease. That is why this patient needs to remain in follow-up. So they have gone for a treatment at some higher center, came back to their village or a small cities. There, the duty of the family practitioner or this local practitioner head, that they have to go for a history examination 3 to 6 months, then 6 months, 12 months, and every 3 to 5 years. Annual cytology from the vault has to be done. Patient education should be done regarding the symptoms, healthy lifestyle, obesity, nutrition, exercise, smoking, these things to be advised according to their disease so as to have a healthy lifestyles. There are few advancement in the disease. Diagnostic technologies, diagnostic challenges. So, see, once we do a lymphadenectomy, there are lot of morbidity कि पैर सूज जाता है, पीडियल एडिमा हो जाता है, पेशेंट को चलने में प्रॉब्लम होती है. तो टेक्नोलॉजी हैज कम दैट where we inject a dye in the cervix and locate where the disease is. If that comes, that is a disease lymph node, we remove that. This is called as sentinel lymph node mapping, and dissection can be easily done. We have a dyes available that can be done laparoscopically also, that can be done during open surgeries also. So this is a very good advancement to track the lymph nodes and remove all those lymph nodes below that level so as to have a complete disease eradication and better survival and recurrence outcomes. So chemoradiotherapy is another. I will go with the radiotherapy only because general is that the radiotherapy की बाल उड़ गए, पेशेंट को बहुत डायरिया होगा, पेशेंट का पूरा बॉडी फ्रेल हो जाएगी. No, there is lot of advancement in the radiotherapy, especially related with the cervix. So now what they do, they give an external beam radiotherapy where they take a CT picture of the area, as you can see here in this figure. They locate the disease. What are the disease part? They mark those points of the cervix and target this radio frequencies at only those points so that the bladder bowel around it is not sacrificed. So this is called as immunomodulatory radiotherapy. And beside this, we give an interstitial therapy. As you can see, the vulval part of the patient where the needles have been inserted at the disease site from outside, and now this required brachytherapy will be given by these iridium needles so that the therapy only goes to the diseased site, because this cervix can be visualized, it can easily be imaged. That is why there is so much of advancement. So very good brachytherapy and teletherapy are available for the treatment of a cervical carcinoma. So to end with, I can say this is a disease which is preventable. We together should work towards the WHO motto of cervical cancer elimination by 2030. 1979, repeatedly I am saying all the adolescent girl should be vaccinated, whether you are a gynecologist, pediatrician, family physician, simple healthcare worker. You must disseminate this information that all the girls between 9 to 14 years, and this vaccination can be extended till the 26th year, these females should be vaccinated. Right? All the females above the age of 30 should be screened between the age of 30 to 50 years at least twice. And out of these patients who have been screened by a pap smear, or villi or HPV DNA, if diagnosed with the disease, should be treated. So 90% of these female should be treated. Only then together we can act against this deadly disease, which causes the mortality every 2 minutes. Surgical treatment is a treatment of choice, and it is available at all government hospitals and the private, it is available government hospital. Majority of the hospitals are, and after the Ayushman Bharat, the cervical cancer treatment is not costly. Actually, it is almost free only. So please don't sit at the home or don't tell the patient that it is costly. You can sit. Treatment is possible. We can act against and we can prevent the disease. That is the most important part which we need to understand. Thank you, Vinita ji, for giving me this opportunity for talking on this disease.
Thank you, Aruna. It was really good and very well appreciated. You have very well defined it. बहुत अच्छा बोला. मतलब it was very nice. Even a layman can very well understand what are the issues, how we can prevent, to manage, and what are the stages, how we have to go. If this is a stage 1, 2, 3, everything is very well defined. Very a great thank to you for this and for entire NHA and everybody from the. So there is a question from Sharda Ota. She is a director in Ayush in Odisha actually. Sharda has written that whether 23 years girl can go for vaccination with these doses, please clarify.
Yes, she can go for a vaccination with 3 doses above the age of, see, India has yet not accepted the 2 doses schedule, I tell you, but she can go for the 3 dose vaccination at 0 to 6. You can choose either a Cervavac or Gardasil because currently Cervarix is not available. The cost of our own vaccine, Cervavac, provided by the government also, it is very less. The 1 dose of Cervavac vaccine in a private costing 2,000 rupees. Gardasil 4 is costing 3,100 rupees. So you can take either of the vaccine. Now the facility for Gardasil 9 vaccine is also available. But please don't think कि ज्यादा वायरस होंगे तो बहुत अच्छा रहेगा. No, please, it is not the concept. The main concept is that we have to target against 16 and 18, which are responsible for more 70% of the cervical carcinoma, and we should be focusing, and we have a cross reactivity against that also. So we are preventing 31, 33, 35 and 55 also. So go for a Cervavac and Gardasil according to the pocket of the patient, and if the government is providing free, nothing like it, please vaccinate.
एक चीज है, मतलब ये मैं, चूंकि सभी तरह के लोग हैं, मैं जानना चाह रही थी कि वैक्सीनेशन हमने लिखा है कि अर्ली 9 to 14 years में वैक्सीनेशन की बात है, तो वैक्सीनेशन
Yes.
उसके बाद करने में भी कोई प्रॉब्लम नहीं है, इफ दे वांट टू गो अहेड, ये कह सकते हैं हम?
हाँ, एक बहुत अच्छा कंसेप्ट है। सी, यंग बच्चों की इम्यूनिटी जो होती है ना, वो बहुत डेवलप हो रही है, तो उस वक्त बहुत अच्छा एंटीबॉडीज डेवलप होते हैं, इसीलिए हम सारा वैक्सीनेशन पैदा होने से चालू करते हैं, एंड कैच द डिजीज और इन्फेक्शन बिफोर इट अकर्स। तो आफ्टर कॉन्सेप्ट इज कि 15, 16, 17 ईयर्स के बाद जो वो है, सेक्सुअल एक्टिविटी स्टार्ट हो ही जाती है मेजॉरिटी। यू कैन नॉट से कि मेरा बच्चा नहीं होगा, दिस इज नॉट, दिस कॉन्सेप्ट हैज टू बी चेंज। So we need to vaccinate so that adequate amount of antibodies are formed by the time they become sexually active. ये नहीं कि मैरिज के पहले लगा लिया। It takes time for antibodies to.
Agreed.
And one more thing I would like to add, Vinita ji, uh, if you have been vaccinated, still you need to go for a pap smear or any method of screening. This doesn't say that you will not go for a screening after the age of 30 years. This concept has to be very clear in your mind.
तो दैट्स व्हाट, जो 50+ के हैं या 45+ के लोग हैं, उनका क्या करना है? क्योंकि ये जो शारदा हैं, उनका ये कहना था कि मैम, वी आर गोइंग टू द रिमोट एरियाज इन उड़ीसा एंड वी आर फाइंडिंग मच ऑफ द पेशेंट एट द एज ऑफ 38-40, तो उससे जब केवल, मतलब वी कैन चेक इट आउट एंड ऑल, बट उस समय वैक्सीनेशन क्या पॉसिबिलिटी?
No. Please, vaccination is not, although it has been advised till the age of 40 years, 45 years, but best is to vaccination done before the 26 years of age. But that is the age, that is 35, 40, patient should be screened because infection तो हो चुका है ना।
स्क्रीनिंग तो वो लोग कर रहे हैं, बिकॉज देर आर मल्टीपल वेज वी आर डूइंग। आयुष ने भी काफी स्क्रीनिंग की, लाइक दे डिड द स्क्रीनिंग फॉर सिकल, उनके कुछ एक मेडिसिन भी निकल के आई फॉर दिस, विच कैन बी एडजुवेंट मेडिसिन। सो दे आर लाइक एवरी मिनिस्ट्री, एक्चुअली बीइंग इन ट्राइबल अफेयर्स, व्हेन आई वाज इन ट्राइबल अफेयर्स, तो मुझे कुछ डिपार्टमेंट से बात करने का मौका मिला, और मैंने आयुष के जरिए कई जगह अलग अलग जरियों पे हम लोग ने स्क्रीनिंग जहां जो कर सकता था करवाई, इसकी भी करवाई, साथ में जेनेटिक डिजीजेस की भी कराई, जो मतलब एरियाज, ग्रे एरियाज थे, स्पेशली ट्राइबल्स में। ट्राइबल में भी ये समस्या बहुत ज्यादा है
हाँ,
कैंसर की, क्योंकि वो
बिल्कुल।
जो मल्टीपल सेक्सुअल वाली बात आ जाती है, वो वहां पे बहुत ज्यादा है, एंड दिस इज अ बिग इशू, स्पेशली इन नॉर्थ ईस्ट एज वेल। तो ये
या
जो है, तो इन वाइल वी वर टॉकिंग अबाउट प्रिवेंशन एंड ऑल दी, कई एनजीओज और सबको लेके काम किया गया था, लेकिन उसमें ये समस्याएं दिख रही थी, तो दैट्स वाज हर कंसर्न। एक कोई, मेरा ख्याल स्निग्धा रानी है, कोई मिश्रा, टू एवरीवन, आई हैव अ सिस्ट, you can read it out, that she has a cyst in her right ovary which is very small, and her uterus is already removed long time back. Is it dangerous?
no, nothing to be done. What is her age?
I don't know, she hasn't written, स्निग्धा रानी मिश्रा करके लिखा हुआ है।
So nothing, very small, less than 5 centimeters is nothing has to be done. See, if you are a young female less than 45, ovulation तो होगा ना, your eggs will form and they will dissolve whether uterus is there or not there. So these are the cysts, small cysts, which go on forming in any of the female. It will form in me also if I am ovulating. So this will occur, that depends upon the day of cycle you have got our ultrasound done.
ये एक शारदा होटा फिर से लिख रही है कि व्हाट इज द इंटरवल बिटवीन 2 doses?
Yeah. So if there are 2 doses, then you have to give 0 and 6 months. And there is no need of booster dose.
Sharda, hope it is clear to you. Sharda, hope it is clear to you. They all are mute, so they might not. Okay, but thank you so much. Any other questions? If we have, you can raise your hands. Nanda, you can ask them to. Acha, thanks, it's clear now. Sharda has written. So thank you, everybody. It was a great talk by Kausar and Aruna as well. And I am privileged that I have two good ladies to speak on this topic. And so I'm overwhelmed, I should say that. It's, I,
Thank you for giving
no, no, it's very close
opportunity.
to my heart as well, because I have been seeing these problems in the tribal areas. Being in tribal ministry, it was a really difficult job for me to see all those things. I mean, during my health camps and all, we had a very good system, but still, we need to do a lot. And thank you all. I mean, Kausar has been doing in preventive, and you have been doing in, I mean, multiple things have been done with good people. And it's a pleasure. I mean, when Kausar came to me for getting the things in tribal, it was very interesting. She said, Ki, why not to start in these things? I said, I have been doing in health camps. No, no, I want a focus thing to be done. So I remember, and I have a privilege of doing all those things. So बहुत अच्छा लगता है कि when people talk so good about these things. And thank you for
And
connecting with us. NHA बहुत धन्यवाद कहेगा आपका, क्योंकि दोनों ही चीजें बहुत important थी. And across the states, people have learned this, and now I think they will also understand कि जो HPQA packages हैं हमारे, उनको कैसे इस्तेमाल भी करना है. कि जब वो स्क्रीनिंग के लिए जाते हैं तो भी पैकेजेस अवेलेबल हैं, जब आप ट्रीटमेंट के लिए जाते हैं तो भी पैकेजेस अवेलेबल हैं. तो एवरीथिंग इज अवेलेबल. इट्स ओनली दैट you know the subject, you know how to do the prevention, and also that what are the stages where we require the treatment as well. So
एक मैं बात कहना चाहूंगी विनीता जी कि क्योंकि मैं सोसाइटी का हमारी इंडियन सोसाइटी ऑफ कॉल्पोस्कोपी एंड सर्वाइकल पैथोलॉजी है जिसका आई एम गोइंग टू बी अ प्रेसिडेंट. सो आई वुड लाइक टू वर्क विथ यू ऑल closely on this because this is the motto of our ISCCP. So
wow,
this is
that's
a national society. So anytime we can work it out, and we all, anybody who wants to educational works, we are ready to do. We are ready to train modules, anything. So we have a good team. So who
oh,
is dedicated for this? We are regularly conducting this modules. Also, anytime if any sort of this thing is required, we are ready to volunteer.
thank you so much. This is very, I'm putting my fingers crossed that that WHO goal for elimination of 2030 will be achieved. And with all your efforts, I mean, you, Kausar, everybody who has joined on this for this cause. So that's very important for us. And on behalf of NHA, I really thank you all again, the
I
experts
have
and
to just
who have
add
joined.
one thing
Yes,
here,
yes, yes.
Vinita ji, that it was only because the premier institute with whom we collaborated was Indian Society of Colposcopy and Cervical Pathology. There were 12 doctors who had nominated provide free services and their guidance because we were not domain experts. We only got the right. We were instruments in just bringing the right people on the table. And Dr. Aruna Nigam was one of those who had offered to provide voluntary services. It is because of their efforts that all the guidelines were tabled. The guidelines for screening for master trainers, for screening by staff nurses, for treatment by master trainers, VIA, thermal ablation, and the set of guidelines were then replicated in 7 other states. So this program would not have been a success without the support of Indian Society of Colposcopy and Cervical Pathology. And I'm so proud to be associated with this organization in a small manner. And it is the fruits of your hard work, Dr. Aruna, that we continue to reap even today. That's the least I can say.
Thank you,
Thank you.
Kausar. Thank you
That's
so much.
really good
It's a
to hear.
pleasure.
That's really good to hear, Kosa, from you and from, I mean, really, I know in depth what has been done in the part. So it's really great to know you people and great to work with you people, rather, I should say like that. So thank you, everybody, and
Thank
thank you
you.
for joining us. It was a great time. It was a good learning to me as well. I mean, every time something or other comes up to learn. So it's really good. And thank you, everybody, for joining us. It's really great. Thank you so much. There is a feedback form. Just write your details so we can communicate to you in future. We want, because these webinars are happening every month. It's like every month we are doing some of the other issues. We take it where the packages are there, they are available, the facilities are available. People should know about what exactly is required. So that's more important, and that's the way we are taking it up. So, but we will again collaborate soon, and we'll come up with some good news. Like Kausar is going to do something good in Bihar, so we will again collaborate for that. Thank you so much. Thanks, everybody. Thank you once again. Thank you.
Thank you so much. So a feedback form has been shared in the chat box. So thank you so much from the experts. So, two key things I can take from the experts, that method of behavioral change of screening, and 90, 70, 90, it will be remembered by everyone, those who have attended this seminar. So, thank you so much, everyone. Thank you so much, Kausar ma'am, Aruna ma'am, and Vinita ma'am. Thank you so much. Simultaneously, feedback form has been shared in the chat box. Please write any queries if you want to ask to the experts, so we can mail them. Thank you so much.
And
Thank
I
you,
would
everyone.
also like that, Aruna, please get your number here. So people who want to connect, of course, and Aruna, both write your mobile numbers if you allow. I mean, it depends on you. If you allow, then we can write your mobile numbers and your mail IDs to get connected, because it will be very helpful for the people in these states itself. Okay. Thank you, Aruna. And your mobile mail ID is with me. Can we share the mail ID, please? If
Yes,
it-
ma'am.
Okay, done. So I'll do it. So this is very helpful. We will send it to the states also. If any of the states wants to connect with you directly, also the states can connect with you. And Kausar, please, if you also don't mind, if it is possible for you, it will be great to us.
Yes, I'm just typing.
It is there. Thank you so much for both of you. Again, once again, a big thank to you. Thank you so much. Thanks.
Okay.
Thoughtful gesture. Thank you very much. Bye-bye.
Bye. Bye.